So, pathophysiology of nausea, vomiting, very complex. This is why when we know what we are dealing with, it is easier to find a solution to it. And so there are many centers that are involved in the nausea. You have the cortex, of course, cerebral cortex, everything passed by there. You have the vomiting center, and you have also, if you look on the different other boxes, you will see to the left the limbic system, which is also involved, the chemoreceptor trigger zone, the CTZ zone that we call. There's also effector organs. That will be example, the stretch of the stomach, example, the GI symptoms, abdominal organs, and the vestibular nuclear. So if we can know that, then we can we can identify what's the target zone or what is the zone that is involved, and therefore you can add a therapy that is according to that. And you will see that. What I give you on the sheet that you do have, you will see not only that you have the zone, but you have also which type of medication will play a role on those zones. And so this is why it's very important when we question. Example, if we have a sense that it is the vestibular nuclear that is involved, well, the patient will tell you every time that I'm moving, the head, whoa, something turnings around, I'm dizzy, and so on and so forth. Well, the treatment will be something very different than it will be if it is something that has to do with the limbic system or the cerebral cortex. The most direct with the cerebral cortex will be the psychological stimuli. So this is the anticipatory nausea example, and for which some Ativan or benzo will be useful. But if it is, example, the abdominal organs that are gastric distension, gastric irritation, hepatitis, so that are really go to the vagus nerve and go to the vomiting center, then probably something that will be useful for that will be something to propulse, something to increase the motility of the gut. Therefore, Reglan will be the best drug of choice. So you see, if you have the proper questioning, this is why when somebody is coming to you and said, well, I'm nauseated, first of all, is that just nausea? Is just nausea and vomiting, combination of? And then you have to ask all the questions that we usually use for pain. When is that? What's the trigger mechanism? What relieve it? What make it worse? And so on and so forth. The 7-8 questions that we ask for the pain and the severity of it as well. So the assessment is one of the most important things to find the right agent. We often see in the floor that patient complain of nausea, well, out of a sudden 3 drugs are prescribed. 3 drugs all at the same time. So what does what? Maybe we don't need 3 drugs. If you expose a patient to too many drugs, you have too many side effects as well, and you don't know what's doing what. So if you ask and you assess your nausea or symptom, you will be able to find out. So you need to know the pattern and the frequencies. That once upon a time, 1 every 24 hours, obviously, if it's 1 every 24 hours, it's not the upper GI obstruction. That won't make sense. That will be maybe a lower GI obstruction or something else. The intensity and the distribution of your, so is it very much? Is it just a little? The triggers, what will causes that? It will be sometimes just the smell of the food that will trigger that. That's really interesting, because usually that will go with something that has to do with the liver. Just when the food, the smell, that triggers that, so probably some liver involvement there. What's the impact on that? It's very important, because when we are going to talk about the treatment, putting or not putting an NG tube, doing this or doing that, you will have to know how disturbing, how distressing it is for the patient. Some patients will rather vomit than having any NG tube put into their system. They will say, it's okay, I can deal with that. I know how to master that now. I know what to expect, and so on and so forth. So, characteristic of the vomiting. Also, what kind of vomiting this is that some blood, no blood, food, no food, so on and so forth, after the meal, all the time, no relation to meal, and so on and so forth. Is there some accompanying symptoms as well with that? I have headache every time I'm vomiting. Well, start thinking maybe there's something in the head, isn't it, that will go mainly with some brain meds or brain primary disease or something there. Is there some pain associated with that? So, you know, it's burning there, then I feel nauseated. Well, maybe there's something that's to do with the GI. Constipation, as you know, all the GI symptoms. GI is a big tract from the mouth to the anus, and then in between there's a lot of things. But it's just a long tract in which a lot of content of secretions are going, and therefore it's important to see if there's a relationship with any of the other part of the GI tract. So, are you constipating or not? You know that one of the first cause of nausea in elderly, probably, and as well as in probably advanced cancer, can be constipation, and we forget about that because we just concentrate on the upper GI. You know, but then we forgot to ask the question, well, how many days? Well, 10 days, 6 days, 5 days, especially in advanced disease when the patient is not eating too much, is sedentary, stay in bed, therefore not much motility, and is more prone to have constipation. Anxiety also, we already talked about the anxiety, how much it can give some nausea. Every one of us who are preparing for exams, sometimes just the day before, we don't feel well, isn't it? We have some queasiness in the GI, we don't feel all that great. So maybe the anxiety can be part of that as well. As you know, anxiety can cause so many things. Review of the medication list. So if you want to do patient, you are investigating your patient for nausea, you have not only to ask those questions, know what kind of disease the patient does have, know if he does have a blockage somewhere, a mass somewhere that can give you that, but also review the list of medication. So what kind of medication is in? And now we have those PharmD students with us. There's no reason now to have a good idea. This can cause that. And we know that some medication, including the antibiotics, that easily can increase the nausea and / vomiting. Also, we should assess the diet. Some food, I'm telling you, can just increase the nausea, including the supplement. Surprisingly, we throw supplement at our patients and take this and take that, and they said, I don't like it. Why? It's good for you. Continue. It's full of vitamin. Well, they will say, well, no, I have gas when I take that, or I have nausea. It's too milky, too sugary, something like that. So assess the diet, and then you can have a sense. The electrolyte disturbances. This is something we always blame that on the cancer, on the disease per se. Sometimes we forget to look at all the electrolytes, and most of the electrolyte disturbances can cause some form of nausea / vomiting. And this is across the board, not only in cancer patients, but also probably in all the other disease, in especially cardiac disease, so on and so forth. So relevant history, we need to know also patient, did they have chemotherapy a week ago, 3 days ago, prior coming and seeing you. It will be very important because there's some drugs that are more specific to target the nausea caused by the chemotherapy, radiation therapy.